This is the second installment of the urinary system's anatomy and physiology, focusing specifically on the physiology component. The kidney's purpose is to filter waste products out of the blood. And so in thinking about what the kidney can do, we think about, one, the filtration, which is happening at the glomerulus within the Bowman's capsule of the renal corpuscle. I said in a previous film that the kidney overdoes it at that filtration, and so then the rest of the nephron has to spend some energy taking back some of those substances and resorbing them back into the peritubular and vasorecta capillary networks. There are also going to be other substances that are secreted into that urine by other tubular cells from the peritubular and vasorecta capillaries, and so we'll talk about all three of those. Going back to what's happening in the renal corpuscle, remember I said the renal corpuscle is made up of two parts, the Bowman's capsule and the glomerulus. The Bowman's capsule is going to be this outer portion, and it is going to be a simple squamous epithelium, whereas the glomerulus is this series of capillaries found within. There are going to be different slits that are in these capillaries that are going to allow some of those bigger molecules to come through. Remember, our other capillary networks that we found throughout the systemic and even the pulmonary systems is that we were just looking at gases going back and forth. Water would be another thing, but we really didn't talk about some of these other bigger things. On these capillaries, do you see these nuclei? These nuclei represent another specialized form of cells called podocytes. And these podocytes have these interdigitations. You can see them in between here. And it's almost like you've got, if this hand represents one podocyte and this one represents another podocyte, you've got these finger-like projections called pedicels. And they interdigitate like this. And it's going to form another kind of filtration, sort of netting, webbing almost, that these structures are going to be able to come through. Your big blood cells are not going to be able to come through here, but those smaller molecules certainly are. Histologically, looking at a kidney, this cluster right here with this white space surrounding it, this is a glomerulus, with a Bowman's capsule being this very thin ring of nuclei around the edge. Okay, so you've got your glomerulus, this is this glob in the center, and your Bowman's capsule is going to be around it, and you've got this empty space in between. And that's where all of this water and glucose and amino acids are all being filtered out of the blood here. What are these circular rings surrounding? Those are just cross sections of those proximal convoluted tubules and distal convoluted tubules. But remember, because they're tubes, when you do a cross section of them, they look circular. And these are going to be simple columnar, or excuse me, simple cuboidal. Do you see the difference between here and here? This one's very clear, but these are fuzzy. The fuzziness tells you that there's a lot of filtration happening there, and there's more villi, and that's the proximal convoluted tubule, whereas the clearer ones are distal convoluted tubules, because we're hoping that by the time it gets to the distal convoluted tubule, there's not a whole lot of resorbing going on. So there you go. Looking closer at the glomerulus, here's your podocyte with the nucleus. The endothelium of the capillary is here. You see there's extra holes here with a basement membrane that is immediately surrounding it. Your podocyte, and then you've got your pedicels. This one kind of creeps me out a little bit, but here's your podocyte, and then here's your interdigitations of your pedicels coming out here from two different cells. I don't know why. But so then this whole thing here would be one of those glomerular capillary tubes, and it's surrounded by these cells. I don't know why it creeps me out so much. Okay. Maybe it's because I really like coffee these days, but I like to equate what's happening at the kidney with making coffee. So if you think about the portions of the kidney and what it's doing, the glomerulus is going to be the filtering. Where does that take place? Well, that's kind of like your filter paper of your coffee pot. I suppose if I have to turn this into a Keurig, it's going to be the little K-cups. The force is going to be, well, gravity when it comes to making coffee, whereas your blood pressure through that afferent arteriole is going to be, the harder you push, the more filtration is going to take place. Also keep in mind that we can control this efferent arteriole to where if we constrict this efferent arteriole, the blood is going to be in the afferent or in the glomerulus longer, and then the pressure from the afferent arteriole coming in is going to actually allow us to push more out. The filtrate, what do we get out of the glomerulus? Well, we're going to have all of these things: glucose, amino acids, our waste products called urea, uric acid, and then something called creatinine. This is actually released by muscle. Ions, sodium, potassium, chlorine. Ooh, wait, hold on. Sodium, potassium, we need that for muscles and nerves. What's going on? And then a lot of water. Well, how do we equate that to coffee? That's the yumminess of the coffee, right? The water plus the coffee flavorings. What don't we lose? We don't lose red blood cells, and that should actually be white blood cells as well, and really big proteins. They can't fit through these pedicels. What doesn't, or what's not supposed to go through the filter paper? Well, the coffee grounds, of course, right? Because that'd be nasty. If you end up with blood in your urine, damage to the nephron, to the glomerulus, is possible, a possible reason. It's not the only reason, but it's a possible reason. The other reasons could be if you've got kidney stones. Kidney stones are not smooth, they are jagged, and they could, well, they could rip through collecting ducts, they can rip through ureters, they can rip through urethras, and that could always result in some blood in your urine, but you know that you'd have to go check that out. When it's all said and done, when you look at this notation here, these brackets represent concentration of. The concentration of the filtrate, meaning all of these is going to equal the concentration of stuff that's on the blood side. Okay, so we're going to have so much move over that it's going to be equal on both sides. Here is about 30 additional pages of PowerPoint, all condensed into one grid. What I want you to, study guide, and I was hoping to be able to pop up the study guide, but apparently it's not playing nice with me, is that for each component of the nephron, I want you to know the type of epithelium. And so 1, 2, 3, 4 out of 6 are simple cuboidal, and the other 2 are simple squamous. So if in your brain you remember, hey, squamous and cuboidal, which ones are squamous? Glomerulus and the descending loop of Henle. Okay, then the rest of them have to be simple cuboidal. You figure out how you're going to memorize that one. You need to know what can cross the epithelium, so to go from the nephron back to the blood, and so from here this is going from blood to urine, and this is going from urine to blood. So if you want to annotate that, blood to urine, and this is going urine back to blood. Okay, so we see that in the glomerulus, water, glucose amino acids, urea, the uric acid, and the creatinine are all coming out, and then you've got these ions. Well, what's going back? Our glucose and amino acids, we don't want to lose those, and we don't want to lose a lot of water. And so where is that happening? It's happening in the proximal convoluted tubule. How does the blood get it back? The peritubular capillaries. In the loop of Henle, we can get water and we can get ions back to the blood. What capillaries are going to be in charge of taking those back? The vasa recta. In the distal convoluted tubule, we want water and sodium back, and the peritubular capillaries are going to do that. Oh, but hold on. We can also, so that's a two-way street. depending on what the body needs. And the collecting duct, both of them go back and forth, depending on what the body needs. And then we see that there are some hormones that are getting in on the deal. And I want to talk about those hormones and how that affects things. What is going to control the filtering at the glomerulus? Something called the juxtaglomerular apparatus. Two parts. In the distal convoluted tubule, we have got, we have got a specialized group of cells right here. That's called the macula densa. Okay, so macula densa. It's just a special group of cells that are going to figure out what our concentrations of things are. And it's really primarily based on how much sodium is in there, because remember, wherever there's sodium, water is going to follow it. And then you've got juxtaglomerular cells. These are going to be surrounding the afferent arteriole, and so JG cells. That doesn't look so good. So if this is one, afferent arteriole, the efferent arteriole is going to be this one, distal convoluted tubule is going to be this, the macula densa cells I've already labeled, so that's 4. And then over here, these purple guys are going to be the juxtaglomerular cells, just to give yourself an orientation. But here's the deal. Check this out. If there's too much flow in the distal convoluted tubule, that is going to talk to the JG cells to secrete a hormone called renin. And renin then goes through the bloodstream, and it's going to turn on an enzyme that's in the liver to angiotensin 2. Or excuse me, angiotensin 1, that's Roman numeral 1. Angiotensin 1, when it then is flowing in the lung, gets converted into angiotensin 2. Then angiotensin 2 comes back to the kidney, and it's going to go to the efferent arteriole, and it is going to constrict it. And when it constricts it, it's going to increase the amount of filtration here. And when the filtration is increased here, it's going to actually increase what we call the glomerular filtration rate. This is how much of the blood is filtered per minute. What I find amazing is that there is such a complex relationship between multiple systems. You've got your urinary system secreting a hormone that is going to activate something from the liver, which is primarily in charge of digestion. That substance from the liver then goes to the lung of the respiratory system, and then that substance then goes back to the kidney, and so it's like a checks and balances kind of a system. The kidney can't control itself. It is going to make sure that the chain of command is followed before it's going to respond. And I think that's pretty amazing. What I would like you to recognize is that this renin from the kidney is going to help control how much of the blood is filtered at any given time. The other two hormones, aldosterone and ADH. ADH is called anti-diuretic hormone. It's also known as vasopressin, but usually ADH is the more common way to talk about it. Aldosterone's purpose is to help make sure that we have enough sodium in our bloodstream. Remember back to first semester. Sodium is required for nerve conduction. It is responsible, or it's involved in muscle contraction. And so making sure that there's enough sodium concentration for the whole body is going to be crucial. So if the body's homeostasis of sodium content is normal, aldosterone levels are low. However, if sodium levels decrease, and what would cause something like that? Probably sweating, because you know that your sweat is pretty salty. So if your salt levels are low, aldosterone is going to be secreted. And aldosterone is secreted by, I believe, the adrenal gland. And when that is secreted, it is going to cause more of these blue channels to be produced and more of these yellow channels to be produced. These yellow channels on what's called the basolateral membrane. This would be the urine side of the collecting duct, so the inside, and this would be the outside of the duct. When sodium levels are low, the body's going to secrete aldosterone. Aldosterone will act on these collecting duct cells to make more sodium-potassium pumps. That's what these are. Remember, sodium-potassium pumps are going to draw 2 potassiums in and pull 3 sodiums out. That is going to decrease the amount of sodium inside the cell and increase the amount of potassiums. By doing that, it also has to make more sodium and potassium channels on this side. And since the amount of sodium is lowering because the blood is trying to pull those sodiums back into it, the draw is going to be for any sodium that's in your urine to be pulled in. And so as sodiums are being forced out back into the blood, diffusion is allowing those sodiums to come from the urine into the cell on the opposite side, and so then you've got this constant draw and release out. ADH's job is to tell the kidney to keep water. And so ADH from the posterior pituitary gland's job is always secreting ADH, and that ADH acts on these cells, on these collecting duct cells, to make channels specifically for water. And when you have lots of water in your collecting duct and you have these channels, it's going to allow the water to creep through. And once it creeps through, then it's able to just pass on the basolateral side, because you have so much water on the inside of the cell. By diffusion, it's going just naturally, osmosis, it's going to go then into your blood. Because we want to make sure that we maintain a certain amount of blood volume, a certain amount of blood pressure. You need water. It's important. Now let's think about this. If you're dehydrated, you're going to secrete both aldosterone to bring sodium and ADH so that the water is kept. Because usually, if you're absorbing water or sodium, water is going to follow. Overhydration is when you take in too much water. Too much water dilutes your blood. And so if you have too much water in your blood, that's going to dilute it. And so that is going to tell your brain, hey, we don't have enough solutes, no concentrations in our blood. Let's turn off ADH, and so that way we don't absorb as much water. And if we don't reabsorb water back into our blood, we're going to pee more. There is such a thing as water poisoning, and that's when you take too much water in. It's called water toxicity, which I didn't think was a real thing, but it is. There were a couple people who died in California because they had a water drinking contest. They drank too much water in a short span of time, and they ended up diluting the blood concentrations of ions, and they ended up dying. It's not a cool thing. But let's think about this. Caffeine and alcohol, when they're in your system, also tell the brain to turn off ADH secretion. So what does that mean? That means that when you have caffeine and alcohol in your bloodstream, and it turns off that hormone, your kidneys say, oh, the body must have plenty of water. And so it doesn't take it back after it's filtered it in the glomerulus. And so that means you end up with too much urine output. And so please, let me tell you this as a myth buster. When you get out into the grown-up world, and you happen to be in a situation where there are alcoholic beverages available, whether or not you're drinking them, but they are, and people will say, oh, whatever you do, don't go to the bathroom, because if you break the seal, then you will be peeing all night long. Here's the deal. By the time you've gone to the bathroom the first time in your evening of either caffeine or alcohol consumption, the ADH in your bloodstream has been reduced. And if it's been reduced, your kidney is no longer receiving a signal to keep the water. And if your kidney is no longer keeping the water, then it's going to be in your bladder. And your bladder is going to continue filling no matter what, until the caffeine and alcohol have been broken down by your liver so that there isn't a concentration of those substances acting on the brain to shut off the ADH secretion. It's not the fact that you've gone to the bathroom the first time. It's the fact that you're messing with your brain. Okay. That's it. Here is the channel language of what's happening. If your ADH levels are normal, then the amount of water that your body needs is minimal. If you're dehydrated, more ADH is going to be secreted, which means you'll have more water channels, which will take more water back from the blood to try and make up for it. Your urine then is going to be darker in color. And so if you want to equate this to, like when you get to summertime and you're dehydrated, if you're dehydrated and your urine is more concentrated, it's darker, more like apple juice in color. Whereas if you are plenty hydrated, it's more like lemonade, a light yellow color. If you are overhydrated, then we're going to no ADH at all, and it's going to be almost clear, except for when you're drinking caffeine or alcohol. And so when you drink caffeine or alcohol and you don't take that water back, what actually happens to your body? You become dehydrated. But the brain can't respond because it's too busy being tricked by the fact that the caffeine and alcohol is present in the blood. And so why do you think people feel so crappy if they've consumed too much caffeine or alcohol? It's because the rest of their body cells are suffering from water loss and they can't keep up. Alright, so now that we've got all the urine into the bladder, because it's gone from the ureter to the bladder then is going to need to empty. There are receptors in the walls of the bladder, being smooth muscle, and when they stretch at about 200 milliliters, there's a signal that goes GVA, because remember GVA is going to be sensory of organs, so you're going to get that signal, and it's going to go to the brain, and it's going to say, hey brain, you can relax your external urethral sphincter if you want. Meanwhile, it's going to send another signal to your smooth muscle, and it's going to start contracting it. The detrusor muscle is going to contract, but until both sphincters are open, it's not going to release. So if you ignore it, like, oh, I don't have time to pee, and I do that all the time. I don't have time to pee. Bladder will forget. And so then, after about an hour, cycle starts over. If you get higher than 500 milliliters, you can force those sphincters to open. You can pee faster, by squeezing your rectus abdominis and oblique muscles and your diaphragm, right, if you're in a hurry. But you're not going to get all of it out. There's always going to be a residual amount of about 10 milliliters when it's all said and done. But this whole reflex of needing to pee is called the micturition reflex. So you can masticate to chew, micturate to pee, and then we know what the third M word is, but we won't talk about that. As your urinary system gets older, your kidneys actually shrink a little bit. 33% of your kidney is what's needed to maintain your homeostasis. But between the ages of 25 and 85, you can have up to 40% of it is going to stop working. If you have high blood pressure, plaque in your arteries, plaque doesn't just form in your coronary arteries and give you a heart attack. If you've got a high concentration of cholesterol and plaque formation, it can happen everywhere. Diabetes is also going to destroy kidney function. If you're going to have plaque in your arteries, and that reduces how much blood gets to your glomerulus, well, that could actually damage your capillaries as well, because those are all cells and they need oxygen, they need glucose. They become less sensitive to ADH, which means you're going to lose water. You're going to dehydrate faster. Your sphincters start to weaken. So you have this leakage factor. When you sneeze or when you cough or when you laugh, you could have squirts. Micturition control affected by stroke, Alzheimer's, or other cerebral cortex problems, specifically the external urethral sphincter. Right? And then in gentlemen, if your prostate becomes inflamed, it's going to choke the urethra. And if it's choked and your stream is a lot less, well then obviously you're not going to be relieve your bladder very well. And that's called urinary retention. And that's why you have to get your prostates checked at least once a year, once you're 40, to make sure that that's not happening. And being a gland made of epithelium, again, epithelium is going to be the types of cells that has the highest mitotic rate. And so for you gentlemen, the prostate gland is going to be the one that is going to result in cancers of sorts for you. All right. The most depressing slide of the whole year. As you get older, your skin loses its elasticity, so it's going to sag and wrinkle everywhere. Skeletal system, osteoporosis, and the hyaline cartilage of your joints starts to wear down, and they start to hurt. Your muscles are going to atrophy. You're not going to be as strong. You're not going to be able to lift as much. You're not going to be able to move as much. Your brain starts to break down. You lose coordination. You start to forget things. And all the smarts that you have start to break down. That's why you should do puzzles. Hormone production is going to go down. And even if your hormones aren't going down, the cell's ability to respond to them, all those doorbells that are supposed to connect to the hormones to change cell function, they're going to stop or be fewer in number. Reduction in peripheral blood flow. So that means you're going to have cold hands and feet. Cold hands and feet. That problem all the time. Reduced sensitivity of the immune system. You're going to get sick more. Elasticity of your lungs decreases. It's not going to stretch as far, which means the amount of air you can take in is going to go down, which means your exchange of oxygen and carbon dioxide is going to go down, which means you are going to get tired faster. Why do you think there's so many benches around a walking path? Old people need to sit down. They get tired. Decreased peristalsis along the GI tract. You don't poop as much. So you see commercials for Metamucil because you have to be regular. They say you should poop 3 times a day. I don't know many people who actually poop 3 times a day. You should have more fiber. Fiber is going to help keep your digestive tract healthy. Decreased peristalsis along the urinary tract. Oh, that means your urine is not going to move along as well from bladder, or excuse me, from kidney to bladder and then bladder through urethra. GFR, how the kidneys filter is going to slow down. And so that means you're not going to get as many waste products out of your blood. And when you have more waste products in your blood, that is going to be terrible for your overall health because they're toxic and too high of concentration. And then we talked about, well, ladies, we lose our purpose in reproduction, and so our uterus shuts down. We stop having estrogen production, which is going to affect all of our other systems even more than just normal aging. And then our sex drives go down. So, the moral of the story, enjoy life now while you are in your prime. That's why they say your late teens, your 20s, and early 30s are the best years of your life. Just remember, you have a lot of opportunity out in front of you. Make sure that you are using your systems the way that they're meant to so that you can get the most out of life. Hope you enjoyed Anatomy and Physiology. I know I have.